One more time, dear President, dear colleagues, I want to thank for having me here in this great program and Congress. And in the next minutes, we are going to present an interesting case. This is a 74-year-old male with symptoms of dyspnea, NYHA class 3 NYHA class 3, coronary artery disease, an onset of transient ischemic attack many years ago with no residual neurological symptomatology, all the cardiovascular risk factors, including diabetes mellitus and restricting lung disease. The patient characterized as, according to the logistic Euroscore, as of high surgical risk. We proceed with assessment of the patient, and we revealed significant aortic valve stenosis with an ERA of 0.8, mild impaired left ventricular ejection fraction, and an Mieghem of 33. The hemodynamic assessment revealed a peak-to-peak gradient more than 50. We proceed with evaluation of the coronaries, so no relevant issues. The patient has pattern grafts in the RCA and the OM and the diagonal branch, and the autography revealed the calcification at the level of the aortic valve, no horizontal aorta, mild paravalvular leakage, and no dilatation of the ascending aorta. The CT analysis revealed a heavily calcified aortic valve, not only at the level of the annulus, but also there was a volume of calcification protruding into the LVOT and having an Agatha score of approximately 2,000. At the same time, we estimate the high of the coronaries, although the right side was protected, and the CT analysis revealed the moderate calcification at the level of the aortic arch and the bovine aortic arch with a common origin of the branchiocephalic tract and the left common carotid arteries. We measure the sinuses. This is an important step during the assessment procedure because here is the place where the native valves are going to land after the implantation of the new valve. And according to the numbers, we decided to proceed with an Evolut R valve, 29 millimeter in dimensions, according to the perimetry of the native aortic valve, which was 55 millimeters. The peripherals were with no relevant issues. They have a sufficient lumen diameter, no relevant angulations, and no circular severe calcification. So the hard team assessment was that we had to deal with a severe aortic valve stenosis, symptomatic with NYHA classification 3. The patient was characterized as high surgical risk, and at the same time, he has characteristics that make this situation as high risk for stroke due to the heavily calcification at the level of the aortic valve, due to the moderate calcification at the level of the aortic arch, and due to the medical history of transient ischemic attack. So we decide to proceed as a hard team with TAVR. We use the transfemoral approach from the right side using the central sheath 60 French as an access point. We proceed with the prosthesis of Evolut R 29 millimeter, and we use cerebral protection device in order to protect the patient for a stroke attack. A few words about the anatomy of this sentinel device. It consists of two filters. There is a proximal filter and a distal filter. The distal filter is located in the left common carotid artery. The proximal filter is located in the branchiocephalic. In between is this articulating sheath, which is 4.5 centimeter in length and has adjustable curve in order to accommodate into the carina at the level of the aortic arch. We have the front handle, which controls the proximal filter. We have the rear handle, which controls and stabilizes the distal filter. In between them, we have the articulating knob. And here is the image of how these filters are going to be located or must be located. The target zone must be approximately 1.5 to 2 centimeters distal from the ostium. And with that, we can proceed with a video of the case. So we have already prepared the contralateral side, which was at that case the left femoral artery and the left femoral vein, introducing 7 French femoral sheaths in both artery and vein. And here you see the anatomy of this sentinel device with a distal sheath here, filter, the proximal filter here. Both filters have a pore size of 140 micros. So afterwards, we, through a Lima catheter and quadracentis, we assess the puncture site, and by using the roadmap technique in that case, we were able to puncture exactly at the point we were wanted to, and that must be above the bifurcation and below the inferior epigastric artery. And then we introduce a pigtail catheter exactly at the level of the aortic arch. You can see the typical bovine anatomy of the arch with a common origin of the branchioencephalic and the left common carotid artery. Thereafter, we deployed 2 proclides at 10 and 2 o'clock, respectively, under fluoroscopic guidance. And then we insert an 8 French sheath at the site of the puncture site. So at the same time, we have already, as you will see here, insert the radial sheath, which was a 6 French radial sheath through which we would insert the sentinel device. And here you see the introduction of the sentinel device up to the aortic arch. We first deployed the first filter, then we stabilize it. This is the first step. We have 3 steps that we have to follow during this procedure. We withdraw the device, and then we start rotating and curving the sheath in between the 2 filters in order to orient towards the left common carotid artery. And here you see the procedure. You see the curve of the articulating sheath exactly at the level of the carina. And then we use a normal PCI wire through which we introduce the sentinel device into the left common carotid artery, deploying and stabilizing the distal filter approximately 2 centimeters distal to the ostium, as you can see here. I don't know, Kostas, if you want to make any comment during this deployment procedure. And
well,
then
the only thing I want to make is that it may be that the curve is formed a little bit further down, and then the wire shoots up in the carotid. So this particular thing that the sentinel device is pointing to the carotid before the wire is operational mostly in bovine arch cases like this one, not in all the cases. I want to make clear that part. Okay, because in the other cases is easier to find the left carotid from the ascending aorta, so we don't manipulate it in the ostium of the innominate, essentially. Yeah, I understand, but that's what I'm saying, that I just want to make clear that if not, whoever is watching, that this may be particularly helpful here, but it's not the general way that this device is used. Okay.
Then we introduce the 60 French sheath, hydrophilic sheath at the right common femoral artery, and then we advance through the sheath from the femoral vein, 5 French temporal pacemaker into the apex of the right ventricle, and we stabilize it. We already start the preparation of the device, Thereafter, we introduce the pigtail catheter deep into the aortic root. And then, by using an Ablatt's left catheter, we insert a normal long wire into the left ventricle. We give many attention lately during this procedure in order not to interact with the different structures of the LVOT, the papillary muscles. We insert the pigtail. At that time, we usually do simultaneously hemodynamic assessment, showing, and then we proceed with a valvuloplasty. Here is a Z-Med balloon, 18 millimeters, with a good stabilized balloon, maybe mild paravalvular leakage, and thereafter we start the deployment of the Evolut R, 29 millimeters in dimensions. We need the projection so the sinuses be aligned, and then we adjust the projection so to have this marked coaxial. The target zone must be 3 to 5 millimeter deep into the LVOT, exactly below the node 1. And we start slowly the deployment. We can deploy the first 1/3 slowly. We don't need always rapid pacing when we use this type of valve. We need also the pigtail as a marker. We try to stabilize the valve and to control the tension. And then we start slowly releasing and deploying the valve. You see slowly the flare coming up. Usually we don't need rapid pacing during such procedure. We want to avoid rapid pacing. We know according to data that multiple rapid pacing can affect the mortality. However, in that case, it was important to stabilize, eliminate the movement due to the cardiac output. And because of the deep implantation, we did a partial receive once here, trying to stabilize and a little bit withdraw the valve at the same time. However, you see again that the deployment is a little bit low, deep into the LVOT. And then we decided one more time to receive the valve because of the deep deployment at time and the paravalvular leakage that we have seen. So one more time, the second time the partial receive, and one more time. You see that at that time the depth of the device was much better compared to previous one. Must be below 10 millimeter, below the first cell. And then according to this hemodynamic behavior and aortography with revealing no severe, no moderate AI, we decided to release the valve. When we do this step, we're trying to release the tension. And here is the final deployment. Always after the deployment of a valve, we check the hemodynamic behavior. We check echocardiographically the paravalvular leakage or any other complications that can be occur. And by aortography also, we check the existence of paravalvular leakage. So here is the aortography coming. Showing a mild paravalvular leakage. We always estimate the paravalvular leakage and the aortic regurgitation hemodynamically, as you see here, having a sufficient diastasis. And then after that, we start withdrawing the cerebral protection device, doing the opposite steps, trying to avoid any strong and force movements. we have to try to avoid resistance. And here is what we see, some embolic debris inside the filter. And at the end, as always, we check the access site. And we see that we didn't have any complication, no perforation, no dissection, no thrombosis, no relevant stenosis. And here is what we faced during that procedure. And by that, I want to thank you for your attention.
Well, I'm glad to see that you caught some debris in the device. Do you know which filter that was from? Or
That was the Sentinel device.
I understand, but which of the two filters, or you know?
Yeah.
From the proximal filter.
Yeah.
So it was from the, yeah, interestingly, they say that most of the debris are directed towards the innominate. So, I mean, that's interesting.
Pure
Minor,
material,
yeah.
but the proximal had this thrombus, two pieces of thrombus
Very
appearing,
distinctive, yeah.
and the white, like amorphous calcium, small, I think.
Yeah, it was a tricky thing, and I think also the repositioning itself also, you know, there's some friction there up and down.
Yeah.
Very difficult to avoid, and obviously at that moment you're really going to get the position right. So you got to do whatever you have to do to get the position right. No question about that.
And the interesting thing here is that it moved down despite the fast pacing the first time. So, and the other interesting point here is that with partial resithing, we were able to move it up on both cases. So
Right.
we didn't need to have a full resith.
And I think that's useful, and I think that's also a good technique for everyone to notice that the device, you need to recapture essentially 75%, and then it sort of comes up a little bit. And you know, I think that's a good feature.
Yeah, you should take advantage of this, because if you do full resith, then you only have two full resithings, and then you have to remove the valve.
That's correct. That comes from the
With-
aneurysm device recommendations. The other aspect is that I don't know what the fast is your fast here with a core valve. We don't use more than 140 with a core valve, but I think you went a little bit higher here. You know, I mean, obviously the Sapien we go super high, but in the core valve, even if we go high, we try to go 100, and if you get breakthrough PVCs, then we go to 120 or 140, and pretty much is off the screen there. But do you use this super high to drop the blood pressure? Or?
I think that was
No.
140.
That's about it. 140.
Usually 120 to 140 fast
This way we
pacing.
can keep it a little bit longer. Like here, you know, you go up and
Yes.
down. It's a little difficult when you're resheathing to stop and then start again. I mean, that's the beauty of the partial resheath, that you
Yeah.
cannot do it
Yeah.
right away.